questions in the chat. The first goes to Fifa A Rahman, representing a CCSO. Fifa, please unmute yourself and make your intervention.
Thank you, Chair. By now, the ACTA co-chairs would have received a civil society letter highlighting our concerns. This is public to read, and I will shortly paste the link in the platform chat box. Our first concern pertains to the fact that the strategic plan and the Dahlberg-led review of the ACTA are two processes running in parallel, and it's unclear to us, at least, how the Dahlberg review has fed into the strategic plan and who is accountable. We'd like greater granularity in who is responsible for the implementation of recommendations and when a check-in will occur. We're also concerned that the draft strategic plan and budget document came to us late. This is not meaningful civil society engagement. There needs to be a discussion on how to involve CSOs at the inception of ideas and not just as a tick-the-box exercise at the end. There are also clear structural issues in some of the co-lead agencies that prevent CSO co-creation and review of strategies and decisions. And these agencies need to participate in a rethink of how poor inclusion of our expertise is hampering response and accountability efforts. We also find it problematic that the health systems work wasn't included in the draft we reviewed, and we look forward to review it as soon as possible. On LMIC involvement, we second Olive Shisana's and Yodi Elakija's comments on the need to include LMICs more extensively. But this goes to something fundamental as to how we operate. If we have a modeling expert and an infectious diseases expert from the Ivy League universities of the global north in our working groups, why don't we have those similar people from the global south in our working groups? Ultimately, this is a question of eliminating colonialism, not just in our structures, but also within us. Third is that with the emergence of molnupiravir and the juxtaposition of the widespread use of antigen RDTs, including self-tests in the global north, there's a real opportunity for test and treat strategies to be deployed globally. The fact that the review doesn't and the plan doesn't include this prominently is a real problem and glaring blind spot in ACTA's vision. And we ask that this be included more prominently in the strategy going forward. And finally, on health systems, we know that there will be work done towards strengthening information systems in COVID-19, for example. But as of now, we have no clarity around work on community health workers, which are an essential resource to bring elderly people, homeless people, mobile populations, and rural populations to vaccination centers and to expose them and help them get access to RDTs. Only 14% of community health workers in Africa are salaried. And to not support CHWs or community health workers is also a massive gap that we'd like addressed. Thank you.
Thank you very much for that intervention.